So, good evening, everybody. We are live now and we can start.
Okay, right. Good evening, everybody. Welcome to this today's webinar, which is brought to you from Paras Hospital, Patna, through Orthopedic Research and Education Foundation, being hosted by OrthoDV. Today, we are going to have the topic for today is going to be patellar instability and recurrent patellar dislocation. And I think this is an area where which is not really very well understood by a lot of orthopedic surgeons. And we have Dr. Arvind Gupta, who's going to tell us about this, because we seem to have to deal with a lot of these problems either primarily or after failed treatment. So over to you, Dr. Arvind.
Thank you, sir. Thank you for the opportunity. Good evening, everybody. So my topic is approach to recurrent dislocation of patella. So I'll start first with this patellofemoral articulation. So in articulation of this patella with the trochlea, in the initial phase, it's remain over the distal part of femoral cortex. And as the angle of flexion increases, the amount of contact also increases between the trochlea and the patella. So at 90 degree of the angle, this is the maximum amount of contact between the trochlea and patella. And after that, there is again there is decrease in the contact. So this is the maximum area where this is in contact between patella and the femur. And the further in the anatomy, the most important structure for this patellar dislocation is the MPFL, medial patellofemoral ligament. Second is trochlear groove. And third one is the quadriceps muscle, which includes the vastus medialis, vastus lateralis, rectus, all these. So let's see the medial patellofemoral ligament first. This is the main stabilizer in initial degree of flexion of the knee. In between 0 to 20 degree, it provides almost 60% stability to the patella. And whenever patella get dislocated, this patella comes this side, this ligament either get ruptured almost in 95% cases, or it get stretched. So this ligament become non-functional. So whenever patella get dislocated, this MPFL almost always get involved. So in the anatomy, it attaches over the patella in the upper 2/3, and on the femur, it is in between the medial epicondyle and the adductor tubercle. So here you can see medial epicondyle is there, and this is attachment for the MPFL. This is the adductor tubercle. So after 20 degree, the patella getting engaged in the trochlear groove, and as angle of the flexion of the knee increases, the articulation between patella and the trochlear groove is also get increased. So trochlear groove is a passive stabilizer of the this patellofemoral articulation. And having said that, the trochlear dysplasia is one of the most common cause for recurrent dislocation of patella. Prevalence is almost in 84% cases of recurrent dislocation of patella. There is some degree of trochlear groove dysplasia is there. And this is not only flattening of the trochlear groove, there may be hypoplasia of the medial facet and the hyperplasia of the lateral facet also. And this was the classification given by the Dizor for trochlear dysplasia. The maximum angle, the normal angle between the medial and the lateral facet is 145 degree. If anything more than that is taken as type 1 dysplasia. And when it is completely flat, then type B. When there is medial facet hypoplasia and lateral is hyperplasia, then it is type C. And when there is a cliff, then it is called as type D, Dijon dysplasia. And its interpretation in the lateral view is there, that we will discuss later on. Many a times the trochlear groove is fine, angle is fine, the patella is fine, everything is fine. But even there is a dislocation of patella. This is because of excessive femoral rotation. When the patella is in normal place, but because of the rotation of the femur, this patella don't sit into the trochlear groove. So this is because of the femoral torsion. So let's see the etiology for the recurrent dislocation of the patella. The first is patella alta, and the placement of patella over the femur is quite high above the trochlear groove. This is again almost involved in 70% of the cases of recurrent dislocation of patella. There is some degree of patella alta association is there. Then trochlear dysplasia is there. Then the hyperlaxity, that is another reason for recurrent dislocation of patella. The trochlear groove is fine, patella positioning is fine, but because of laxity of the ligament, there is dislocation of the patella. Then there is muscular weakness, particularly the vastus medialis obliquus, which is the dynamic stabilizer of the patella. When this get weakened, then again there is chances of dislocation of patella is there. Lateral side, that is the vastus lateralis, lateral retinaculum, IT band. When it is tight, then with the flexion, this pulls the patella lateral side. So this is another reason for it. Then the malalignment of the lower limb. If there is external rotation of the tibia, excessive anteversion of the femur, genu valgum, increased Q angle, all these factors pushing the patella on the lateral side. So leads to dislocation of patella on the left. This is for the valgus. Then many a time there is traumatic dislocation of patella is there. All the structure are fine, but patella get dislocated because of trauma, and sometimes iatrogenic also. So let's start with the physical examination. In the physical examination, first standing alignment should be checked. Again, for the valgus, the external rotation of the tibia, excessive anteversion, and the foot pronation is there, valgus is there. All these factors in a standing position should be checked. Then the Q angle should be calculated. This Q angle is the pull of the quadriceps muscle over the patella and the direction of force in the patellar tendon. And this from the center of the patella to the anterior superior iliac spine, and from the center of patella to the tibial tuberosity, the angle form is the Q angle. And in female, almost 18 degree up to 18 degree is normal. This in female, this is more than the males because of the wider pelvis. Then check for the femoral version. This should be done in the prone position. The rotation of the lower limb should be done with the knee flexion, and check for the trochanter. That should be the parallel to the table. And this angle should be measured. The normal is 8 to 15 degree. Anything more than that is taken as the excessive femoral version. And how this affect this, with the increasing the anteversion of the femur, the patella gets subluxated on the lateral side. The lateral facet also get pressed over the lateral facet of the trochlea. So there is also pain, the increased pressure on the lateral compartment, and there is chances of dislocation of the patella when there is excessive femoral anteversion. The next test is the apprehension test. The knee should be 30 degree flex. That can be done by either putting the thigh under the knee, or then displace the patella from the medial to the lateral side. When there is apprehension, either he will stop and there will be pain, or there will be pain from the patient side. He will stop you from doing this. The next is the patellar glide test. This compartment will be divided into the 4 parts, and check for the shifting of the patella. The 1 or 2 compartment movement either on the medial or lateral side is fine. If it is more than that, then this should be taken as the pathological. And this shifting should be done both on the medial side as well as on the lateral side. Then the J sign, and this test should be done when the knee is flexed around 90 degree, and then extend the knee from flexion to the extension. And then in the terminal part of extension, sudden movement of the patella on the lateral side. This is mostly because of either trochlear dysplasia or patella alta. Next is the tilt test. When the lateral facet of the patella get tilted with the hand, and then this become not possible when there is a tightness of the lateral structure on the knee joint. And then after all these tests, the radiological examination should be done. This should be start with the standing AP view for both the knee, and when there is persistent dislocation, that can be appreciated on the AP view also. Then in the lateral view, look for the patellar height and the trochlear dysplasia both. So patellar height measurement has been given by many, like Insal Salvati index first, then this was modified because this lower pole of patella was not taken into significance, so this was modified. Then the Catton-Deschamps index was there, and the articular surface of the patella, and from the margin tip, anterior tip margin of this tibia and the lower pole of patella, this ratio was measured. Then the recently Blackburn Peel index is there, the tangential line around the articular surface of the tibia, and the length between this point and lower pole of the patella and the articular surface of the patella ratio was measured. So usually Blackburn Peel more than 1, and Catton-Deschamps is more than 1.2, or modified Insal Salvati is more than 2 is taken as patella alta. So in the lateral view, we also appreciate the trochlear dysplasia also at the same time. So this is the standard lateral view of the knee joint. This blue line is for the central trochlea, and this is red line is the medial condyle of the femur, and the green one is the lateral condyle of the femur. So ideally, this central trochlea should be below this line, and the medial and lateral side line, both the lines should be coincides to each other. But with the dysplasia of this trochlea, when the angle is more than 145 degree, it means this the trochlear groove is coming more anterior. So with the lateral view, we'll see this trochlear view, this trochlear line is coming anteriorly. So this is not below the articular, this condylar margin. So this is called as crossing sign, and this trochlea become flat. So somewhere it's come as a spur anterior to the cortex, distal part of the cortex. So this is called as a spur. This is type B dysplasia. And there is lateral convexity, that is lateral condyle is hyperplagic and the medial condyle is hypoplagic. Then there will be 2 lines, one for the lateral cortex and another for the medial cortex. So there will be 2 lines, that is called as double contour. And when there is this cliff, so this cliff will appear as a spur, as well as because of this hyperplasia and hypoplasia, there will be double contour. So this is called as type D dysplasia. This recognition is very important for the management of recurrent dislocation of patella, because this type of dysplasia is always there in almost more than 80% of the cases of recurrent dislocation of patella, and treatment vary according to dysplasia of the trochlea. So the next is the merchant view, where we can calculate the sulcus angle, congruence angle, the lateral patellofemoral angle is also, all these 3 can be calculated with the merchant view. At the same time, there is subluxation of the patella or dislocation of the patella, and always should be done for the both the knee. And also this merchant view angle of flexion of the knee at the time of X-ray should be decided by your clinical examination. Like this merchant view patellofemoral articulation at 60 degrees is absolutely fine, but at the angle of 20 degree of flexion, this merchant view says there is dislocation of the patella. So this knee was getting dislocated at 20 to 30 degree, but at 60 degree this was fine. So your merchant view angle should be decided by your clinical examination. The next is long standing fill to look for the valgus. Like this, there was a valgus and little bit of valgus in comparison to this side. And as the knee get flexed, you can see there is subluxation of patella. Then recently CT scan and MRI should, at least CT scan should be done in all the cases of patellar dislocation to look for the torsional profile, femoral anteversion, excessive tibial torsion. At the same time, this TTTG distance is also get calculated with the help of CT scan. Patellar tilt, trochlear depth, all these very accurately measured by CT scan. About this TTTG distance, usually it should be less than 20 millimeter. Anything more than 20 millimeter is taken as abnormal TTTG distance, and surgical indication is there. Basically, this is the imaging method of measuring the Q angle. So the placement of the tibial tuberosity in comparison to the trochlear groove. So when it is more on the lateral side, so this the Q angle will be more, and this get depicted with the TTTG distance by CT and MRI. The next is MRI. MRI will tell about the MPFL condition. In acute dislocation, there is osteochondral fragment will be there, cartilage injury and impaction will be there. TTTG distance will be calculated with the MRI. And recently, the classification for the trochlear dysplasia was also introduced by the MRI also. So this was the X-ray, says there is MPFL tear is there. This is the lateral side, medial side of the patella, shows there is MPFL tear again. And this is impaction over the lateral condyle of the femur. All these, this is the acute case of this dislocation of patella, MRI thing. So next is the management. In the surgical, this non-surgical management, usually the quadriceps exercises and the core group like pelvic muscle, abductor, hip muscles, all these exercises is needed. Those who are having recurrent subluxation type of thing. But those who are having recurrent dislocation usually don't get managed with non-surgical management. Those who are having acute dislocation, first time dislocation of the patella can be managed with surgical management. Can be managed with conservative treatment, the first time dislocator. But those who are having recurrent dislocation of the patella, that is very frank, usually needs surgical treatment. And the surgical management can be done all around the patella and at the trochlea also. So in the superior part, there is proximal realignment procedure like the VMO part. On the medial side, there is MPFL reconstruction or repair is there, or VMO reefing is there. On the lateral side, the release of the lateral structure. And in the inferior part, for the soft tissue procedure, there is Rock's Goldwith and the Imslide trialet. And the bony procedure is the Fulkerson osteotomy. So let's see on the medial side. Medial side having option from repair to advancement to MPFL reconstruction. About the primary repair of MPFL and the medial structure is there. The literature says there is no significant difference in redislocation rate, those who get repair or those who get managed conservatively. Again, in the JBGS 2008 says the repair of the torn medial stabilizing soft tissue structure is not advocated for the first time dislocation. So those who are having recurrent dislocation, there is concept for the MPFL reconstruction, and this reconstruction needed almost each and every cases of dislocation surgery, whether it's the TT Fulkerson osteotomy or tracheoplasty surgery or any rotation surgery. In mostly cases, this MPFL is either torn or stretched. So recently teacher says this surgery should be done almost each and every cases. So in this, the insertion over the femoral part is the key for the isometry. So this is calculated on the C-arm. And this is the point where it should be done. And it can be done single bundle, double bundle, anything, use suture, loop tunnel, tenodesis, and literature says there is no significant difference. Over the patella, it should be the upper half. And usually isolated MPFL reconstruction should be done, those who are having instability in 0 to 30 degree. And also dysplasia is low grade, usually type A or type B type of dysplasia of the trochlea without significant patella alta. The isolated MPFL reconstruction should be done. Like in this case, the isolated MPFL reconstruction was done. Another case, this 32-year male having first time dislocation followed by recurrent subluxation of the patella. This was the loose body osteochondral fragment, removal done. And this is the intra picture. You can see the initial phase of the knee flexion. This patella goes on the lateral condyle of the femur. So this was the recurrent subluxation. So isolated MPFL reconstruction was done. This is in the upper half of the patella, that is more important. Also, this is the subtle point, this is called for the insertion of the femur. And finally, this loop technique over the lateral side of the patella. So after this MPFL reconstruction, another surgery for this recurrent dislocation of patella is the tibial tubercle transfer. This usually done for patella alta and those who are having increased TTTG distance. It means there is lateral placement of the tibial tuberosity. So surgery, recently the medialization as well as the anterioralization of the tibial tuberosity was decided. Initially, it was only medialization, but now Fulkerson is very commonly performed surgery for recurrent dislocation of patella with increased TTTG distance, which make the tibial tuberosity anterior as well as the medial. So where is the diagram? It says the usually 10 to 15 millimeter of anterioralization and on 5 to 10 millimeter of medialization is good enough. This was only for the anterior medialization, and this is for the anteromedial. This was the case, again, recurrent subluxation of the patella. And this says there is dislocation, subluxation of the patella, and also there is B type of dysplasia of the trochlea also. So this was treated with only MPFL. You can see only Fulkerson osteotomy. You can see there was distalization of the tibial tuberosity was also done because there was no frank dislocation. It was recurrent subluxation of this patella. So the patella alta part was taken care as well as the Q angle was corrected. Next is the tracheoplasty, usually indicated in type B and type D. And because of this, instability will be usually in 0 to 60 degree of the angle. And this is the recent classification, MRI classification. So this spur should be calculated if anything more than 5 millimeter or sulcus angle more than 145 degree. Surgery should be done for this infirma tracheoplasty. So this is the recent literature in 2020, 2-year follow-up. So almost 100% return to work with 85% return to sports, no arthritic changes, but it was only 2-year study. So for this tracheoplasty, quantification on MRI is mandatory. And this can be done with either with the help of jig to release the cartilage from the bone. And this flap is there. And after that, take the bone from here, the amount of you want to decrease the bump from the lateral side of the trochlea, and then the use of swivel layer and this suture, biodegradable suture over this, and this is done. This can be done with the help of the chisel also after removal of, but this is along with the cartilage, you have to take some bone also, and in the x-ray this would be look like this. So sometimes there is dislocation in flexion also. You can see in the extension, the patella is in groove, but as the knee get flexion more than 90 degree, this get dislocated on the lateral side. So in those who are having dislocation in flexion, usually either lateral side structure is very tight, or there is femoral rotation is there, or tibial external rotation is there, or excessive anteversion is there. So usually this type of patient needs femoral derotation osteotomy to decrease the anteversion as well as rotation. So some discussion about the pediatric recurrent dislocation, because most of the patella get dislocated in pediatric age group only. It has started from the pediatric age group. Almost more than 70% of recurrent dislocation of patella having episodes of dislocation of patella in their less than 20 year of age group. So this was the case. Here you can see the torn MPFL with some grade of trochlear dysplasia also, and there was a little bit of this component of little bit of patella alta also. So all the three component was there, but since this was the pediatric age group, so usually in pediatric age group the bony procedure is not recommended. So only soft tissue procedure should be done. So traditionally, the proximal realignment and distal realignment procedure, lot of procedure has been given. In which the favored one is modified Rooks goes with procedure. In which the lateral half of the patellar tendon is released and gets sutured on the medial side. So this prevents the lateral subluxation of the patella, as well as the VMO advancement is also done. Another surgery for those skeletally immature athlete is the Galliagi, when is the semity is taken and drill into the patella and get suture over that. So this act as a check-in. So in this case, the rocks go with the lateral release and the MPFL reconstruction was done. For reconstructing the MPFL in pediatric age group, ideally this subtle point in adult is there, but this should be in pediatric should be placed distal to the physis. So this was done in this case. Thank you.
Thanks, Arvind. There's a lot of information there, which I hope everyone found useful. I think this is just to bring to everyone's notice that patellar dislocation has a multiple components and factors which you need to look at when you're assessing these patients, and you need to deal with these problems in your surgery, otherwise you're not going to be successful. So any questions, and we'll continue the discussion on it. I'm sure there should be a lot of questions. So one area which we don't see so much today is we used to see a lot of this, I think in maybe 10, 15 years ago, where it used to be just the tight vastus lateralis getting a contracture due to injections, post-injection contractures of the vastus lateralis. And there you only had to do an extensive release of the vastus lateralis to get it reduced. But again, you have to assess these patients carefully to know that that is the only problem. I think a lot of these patients would also need, today, most of these patients would need a combination of procedures. And I think the importance of the MPFL is something which has only been recognized more recently. When people did other things to pull on the medial side, like tendon transfers and tendon insertions into the medial side, but without really understanding the anatomy of the MPFL, which today we find is very often the main factor that you need to deal with when you're sort of dealing with these recurrent dislocations. And again, that's the vastus lateralis contractures will dislocate in flexion as opposed to some of the other problems with the MPFL or the trochlear dysplasias where you get more dislocation in extension rather than flexion.
So, TNVs, if you have any question, please ask.
Sir, only lateral release is option.
That
For
is an
any
option only for that particular type. That's why I brought that up. That is not
Yes.
something we see very often today, but used to see a lot many years ago. Where you just have a post-injection contracture of the vastus lateralis.
Yes,
So,
sir.
so the idea is that you deal with what the pathology is when you're doing your surgery.
Yes, sir. But only lateral release can lead to medial subluxation or more lateral subluxation.
Why will lateral release lead to lateral subluxation?
This will may leads to medial subluxation when
It
lateral
can.
adductor is not tight and you have released the lateral side and done
Yes.
something on the medial side. And when the lateral side is not a culprit, but you have released extensive release on the lateral side. So just like the MPFL, medial patellofemoral ligament concept on the medial side, similar concept on the lateral side also recently growing. So that structure get released when it was not needed, then there is chances of medial subluxation of patella, but that is very rare.
Sir, when we say lateral release, that means we release lateral vastus lateralis or lateral retinaculum also.
So,
Yeah. Sir.
Yeah. So again, today, what I was talking about is a particular pathology where the entire vastus lateralis was really contracted. Okay, that's not something we see so often today, but you would see it in very small children, 4-year-old, 5-year-old, and obviously they would come late with complete dislocation or with a dislocated patella rather than a recurrent dislocation. Okay, and there you had to keep releasing the vastus lateralis quite a lot, sometimes a long way up, to get the patella tracking in the right direction. Okay, so there the pathology was not MPFL because MPFL was okay. It was not any anatomical abnormality because those were okay. It was basically, now if this is allowed to continue like that, you will end up with problems in the trochlea, everything. Okay. But if you catch them early, sometimes all you need to do is a lateral release. But that is unusual today. If you try to do that for every patellar dislocation, that's not going to work.
Sir,
sir, that is
reason of
Gautam?
quadriceps wasting, sir.
This may be because of trauma, maybe because of some neurology, maybe because of iatrogenic. So this vastus medialis obliquus is very important dynamic stabilizer of this patella.
Yes.
So when that atrophy or non-functional this vastus medialis obliquus may leads to dislocation of patella on the lateral side.
Yeah, and so when you're treating them conservatively, you have to concentrate on strengthening the quadriceps, but concentrate more on the medial. Unlike when you're doing for OA, you would be strengthening the TFF more. Here we have to strengthen the vastus medialis more.
Okay, sir. One more query, sir. There is a hypoplasia of medial condyle or lateral condyle, sir?
Hypoplasia of the medial condyle and the hyperplasia of the lateral condyle.
And there is also, sir, lateral shifting of tibial tubercle.
Yeah, lateral shifting of the tibial tuberosity.
That's why you pulled more laterally, no?
Yes,
yeah.
Sir.
Your Q angle get increased and the pull on the patella is more on the lateral side. And this, sometimes the placement of tibial tuberosity over the tibia is fine, but the excessive external rotation of this tibia may leads to this problem.
So this concept of trochleoplasty, okay? Now, isn't the problem sometimes of the groove and the slope of the lateral side as well? Because it's not, you don't have an adequate groove and you need to recreate a groove when you're doing your trocheoplasty.
Like hypoplasia of trochlea, sir.
Yeah.
Yeah.
So don't you create that elevation on the lateral side in those?
Oh, yes, sir. For this grooving, yeah, definitely. Just remove the bump that spur is there, and this angle should be created at least 140 degree of.
Yeah, so you need to actually do it. It's a long time since we've done this particular procedure, but where you actually do not a complete osteotomy, but a incomplete osteotomy, actually elevate the lateral part of the articular area and then put in bone graft underneath to hold it there.
Other way.
Okay,
Now
so that
Sorry? Arvind, you were saying something?
yeah. Nowadays, there is two type of surgeries documented for tracheoplasty. One is osteochondral segment removal. Another is only chondral part, that is the cartilage part should be separated and remove the excessive bone because of hyperplasia, and then cut the cartilage and bone in the center and then create the groove.
Okay.
Sir, TT-PCL distance is something.
Yeah, and recently tibial tuberosity PCL distance is measured because this recurrent dislocation of patella, those who are having TTTG problem, already having some component of trochlear dysplasia.
Yes.
So center of trochlear dysplasia determining in this type of cases sometimes become difficult. But the PCL insertion is very accurate. So nowadays, recent paper last year was there in the Orthoscopy Journal, says that tibial tuberosity PCL distance is more reliable in comparison to TTTG distance, but I still need to lot of paper and research over that.
Okay.
These are trying to make minor differences in what you calculate to. But I think the important thing of the Fulkerson osteotomy is when you lateralizing the tibial tubercle, if you make a horizontal cut, medialize it, you will actually also shift the tubercle posteriorly.
Anteriorly.
Anteromedialization.
No. When you're doing a horizontal thing,
yes,
if you don't slope it, okay?
Yeah.
If you don't slope your cut, when you move it medially, you will end up, because there's a slope in the proximal tibia, and when you medialize it, you'll end up shifting it posteriorly as well.
Yeah, in previous cases of osteotomy.
So that's the reason you make your cut slightly obliquely, so that the medial side is higher, the lateral side is lower. And when you translate, you're actually anteriorizing your tibial tubercle. So the contact pressure on the patella will reduce.
Yes.
Yeah. So this is the concept of Fulkerson osteotomy is there, anterialization as well as the medialization.
Medialization, yes, sir.
And sir, how you identify MPFL during operation?
So MPFL during operation.
Yeah, how to identify, sir? Because that is.
So this is, you mean to say for the repair, or what do you mean to say?
No. Yeah.
Intra-op identification during repair.
Intraoperative, sir.
You don't need to search for MPFL. You just have to find out the total point, which was in between the medial epicondyle and the adductor tubercle. There is a depression over there over the femur in between these two elevation. And on the patella, it should be the upper half or upper 2/3 at least. And the two tunnels should be in the patella at the distance of 10 millimeter.
So basically the MPFL is really just a condensation of the tissue in that region. Okay, it's not a well-defined ligament as you might find in other parts like the medial collateral ligament or the lateral collateral ligament. It's a condensation of the capsular structures in that region. Okay, And that's why it had not been well understood earlier, because it was thought to be part of the capsule. So when you do a normal knee, try looking for it and understanding what it is. It will not be a separate structure altogether. Okay? And that's why there are some people who say, oh, it doesn't exist. It is just.
Only thing important at the time of reconstruction, one is the isometry point that should be exactly matched. And another thing, it should be in between the second and third layer of the dissection, just above the capsule and below the sartorial fascia and all.
And sir, how often you take MRI scan when you are planning for surgery?
What's
MRI.
MRI, sir.
MRI. I think almost if you're doing MPFL reconstruction, that's the only way you can actually diagnose a tear or a stretch of the MPFL. Huh?
And also nowadays there is classification for the trochlear dysplasia with the MRI, and also how much you need to, if you are planning for tracheoplasty, so how much you need to be excised, you can calculate from there. So MRI and CT is almost each and every cases for recurrent dislocation of patella.
Yeah, and at least CT, MRI is almost always, and CT where if you think there's a trochlear dysplasia or some other bony anatomical problem, then you need to do a CT also.
And those who are having the first time dislocator, the MRI is mandatory in this case because of chances of osteochondral fragment, which may missed with the X-ray. So first time dislocator should be evaluated with MRI.
Yeah, in fact, we've had a few cases like that. You may sometimes see a small speck of bone in the joint, which gets missed very often. And when you actually do an MRI, you find it's a much larger fragment than you think based on the X-rays. And sometimes it can be a loose body as well.
Yeah.
So there may not be any attachment to it as well.
Yeah, we have treated one patient for loose body, and later on it comes to recurrent subluxation of patella orthoscopically. So we did this fulcrum osteotomy in that case.
Yeah.
So you have mentioned about merchant view in different angles. Like if few patient is having habitual dislocation at 30 degree, few is having at 50 degree. So at that point we should take the X-ray. Means how to decide at which angle we should.
Yeah, so mostly your recurrent dislocation of patella is the clinical diagnosis. Your radiological investigation aided in finding the other pathology associated with this. So if your patella get dislocated in 30 degree, 30 to 40 degree, so you write your merchant view should be done in 40 degree, because if you do in 60 degree, then it will be normal. In 60 degree, your trochlea will get engaged with, patella will get engaged with the trochlea. So in that case, it will be looks stable. And those who get dislocated in 60 degree, and if you merchant will be in 30 degree, it will be normal. But in 60 to 70 degree, this will be dislocated. So you can vary your angle of merchant view according to your clinical assessment of your recurrent dislocation of patella.
And sir mentioned one iatrogenic cause of injection, and any other iatrogenic cause we can suspect, sir?
Yeah.
In etiology.
Because of your any intervention, vastus medialis get weak, or MPFL get weak or stretch. All these pathology may lead to recurrent dislocation of patella.
Even that is because of if it is disuse atrophy, in which one the vastus medialis is weak, that also can cause this dislocation, sir.
Recurrent subluxation, many a time we find that.
Yeah, but you don't. So why could you get? So you disuse atrophy is usually following some problem, yeah. Otherwise, why would you not use that knee?
Yes.
So you have injury or something like that, or some reason for not using the knee to give you disuse atrophy.
And sir, one question from pathoanatomy, sir. You have mentioned about supratrochlear spur. So that spur is at lateral side?
It's not the supratracheal spur, it's the trochlear spur, which you find in the lateral view.
in the lateral view. So that is on lateral side, sir, or it is?
Yeah, mostly a spur in the lateral facet of the trochlea, and sometimes cliff, which is just lateral to the center of the trochlea.
Okay, sir. And there are a few radiological points. I think you have mentioned about that crossing sign and also double contour.
Yeah.
So that one we can on the X-ray it itself. So
Yeah,
whatever
so
you have mentioned.
Yeah, so Dijor has given classification for this, and he calculated all these on the lateral view. So
True lateral, sir.
yeah, true lateral. Usually your trochlea is down in comparison to your condyle of the femur. So in lateral view, condyle will be more prominent in comparison to the trochlea. So trochlea line will be different, and the condylar line will be different. But when there is shallowing or flattening of this trochlea, so this line comes more anterior in lateral view. So that is called as crossing sign. And when there is the flattening or hyperplastic lateral condyle of the femur, this will comes as a spur. But when there is extra bone, that is called as cliff in the trochlea, then this will be double contour is hypoplastic medial condyle and hyperplastic lateral condyle. And there is extra cliff is there, then again this will be seen as a spur on the lateral view.
Okay, so you should not get too carried away with this trochlear pure lateral X-ray signs. They're not so easy to
Calculate,
see easily. Okay, so and it's not something not always a part of your surgery, trochleoplasty. So I think those are. I think what's important for you to is understand the various anatomical and biomechanical factors which can lead to this problem and identify the main factors involved in a particular case and deal with them in your surgery. Okay, so otherwise, that's the reason you get so many failures is people just do a lateral release or a medialization and or just a lateral release and medial umbilication or tightening, and that often is not enough because you need to deal with if there's a valgus problem or a torsional problem. Unless you deal with it, any surgery you do is also going to be unsuccessful. So there are cases where we've also done apart from the medialization of the tibial tubercle lateral release and the MPFL, we've also needed to do an osteotomy to correct the bony anatomy of the femur. Okay, so you need to deal with all the factors if you want to stop it from happening again. Otherwise, you're going to get recurrences. And
also the trochlear dysplasia type D usually need tracheoplasty.
Yeah, others don't.
Mostly people, all the type 1, type A, type B, type C usually do with either Fulkerson osteotomy or MPFL reconstruction type of thing.
And for that, really, you need the MRI and CT to really get a good diagnosis. Very difficult to just see it based on lateral X-rays. I mean, de jure might be able to tell you, but or if you actually take out 10 X-rays, you'll find it very difficult to understand exactly what it is just based on a lateral X-ray.
And sir, you have mentioned about the conservative treatment in first-time dislocator. So what type of conservative treatment, sir?
So conservative treatment is again you should focus on the strengthening of your VMO muscle and the core group of muscle. Usually those particularly hyperlax type of patient is there get subluxated or dislocated patella first time. Not very violent traumatic injury is there. Such type of patient get very well treated with conservative management with a strengthening of VMO quadriceps and the gluteus muscle strengthening and the hip group of muscle strengthening is also very important.
Just one last question, sir.
Do braces help at all?
So just for the pain part, for initial 7 to 10 days for initial dislocator. Otherwise, they say this should be avoided because with the brace, the VMO atrophy is very
actually even more.
Yeah, in very short time.
Sir, and how much chance of it is going for second dislocation, sir, if someone is having first dislocation?
So it's depend upon what are the pathology associated with and the severity of the pathology. If high grade of trochlear dysplasia is there, patella alta level is very high, then the chances of redislocation is very high in such type of cases.
Almost 60%, sir.
Yeah, in almost 60%. And those who have been just very less energy trauma is there, and there is dislocation or subluxation of patella, and then such type of injury usually get treated with conservative management. Chances of recurrent dislocation is very less if there is no associated pathology. Because initially, those who are having multi-ligament injury having dislocation of patella also. So in 2 cases, I did MPFL reconstruction along with reconstruction of all the ligament. But nowadays, I don't do any thing with the
patella
dislocation, but none of these patients says about the dislocation or subluxation of patella.
I think what is important to understand is almost always any patient who has a patellar dislocation will have some underlying problem in anatomy which you need to look for, okay? So whenever you get a patellar dislocation, just don't treat it based that the patella is dislocated. All I need to do is brace it, it'll be okay. You need to look for what was the cause. They almost always have a predisposition to it happening, and which you need to look for. And then you have to deal with that. Okay, if every normal person, if he will not dislocate his patella, tear his ACL, he'll do something else, okay? When they fall. There's some underlying this thing with the pull where the patella tends to get pulled laterally when the injury is happening that causes this dislocation. Or similarly, you very rarely see medial dislocation, okay? It has to have some other reason for to have a medial dislocation. Most likely iatrogenic or something like that.
Sir, about the MPFL reconstruction you have mentioned, there is something MPFL repair can also exist, sir? Or?
I think if you're not listening, Janki,
repair.
So yeah, you do repair or do conservative treatment for dislocation of the patella. Result is almost same.
In an acute case, a lot of people thought that rather than do a reconstruction, you can just repair it, and we've also done it. I have to say that we've done it, and usually it just stretches out. Whatever repair you do, it just stretches out, and they may or may not get a second dislocation, but there's always some instability there in that patella. So it's not much better than just conservative treatment. So if you're going to get better with just repair, you'll probably get better with conservative treatment as well.
So there is indication for surgery in first time dislocator, like osteochondral fracture is there. So in such type of cases, the urgent surgery, immediate surgery should be done. Yeah, and so rest patients should be given trial for the conservative treatment and see if it dislocates, then go for surgery.
So rarely you may have this, where it's actually avulsed from the patella with the MPFL, and then if the fragment is large enough, you can actually fix the fragment back. I think we've done 1 or 2 where we used these disposable K-wires as well, biopins, etc. to fix it.
Okay, sir. So that surgery you do arthroscopically, sir, for osteochondral fragment?
No, it's open surgery.
You can diagnose it arthroscopically, but you need to repair it openly. It's not a huge open surgery, but yeah, you need to open it. And
in patella, you can do orthoscopic lateral retinaculum release or medial side reefing orthoscopically. That's it. Rest surgery you have to do by open method only.
So this lateral arthroscopic release was very common. It's still done occasionally, but used to be very commonly done at one time, based on with patients with anterior knee pain and just arthroscopic diagnosis that the lateral structures were tight or something like that. And I think the results are not that great. Yeah. but it does work in some of them, because I know some people who've got relief from that because of the pressure that they have. When you release it, that pain decreases, but it has its own complication. No.
Yeah. We have done in one cases at Paras Hospital also, that lateral patellofemoral compression was there and orthoscopically released it well. Though she was very keen for exercise also. So again, this is very difficult to say.
No, so I think it, especially today with the sort of underwater diathermy, it's safe to do. Early on, I've seen quite a few bleeding problems with it before that, where you should just do a knife release, etc. But with this instruments that we have today, you can do it pretty safely as well.
And sir, just one question with for DNB point of view, that you have mentioned a few other ratios other than insult salivity, like black bone peel and all. So how much important is to remember it for examination point of view, and which one is most important right now? If you can
so
say.
Caton Deschamps is taken as one of the most specific in comparison to insult salivity or black bone peel. So if specificity wise, the literature says this Caton Deschamps is having highest specificity.
I think you should know that, and one of these insol ones, because that's historically the one that was used. Insol salivity, one of those, because that's something if you do have a case, the examiner is bound to ask you. He may not know about blackburn peel, but he'll know about insol
salivity.
Yes.
Sir, post-op protocol after MPFL reconstruction, sir.
So passive range of motion should be started immediately. At the same time, the isometric contraction of the VMO and this all quadriceps muscle. And
Yes,
with the walking with the help of brace with some weight bearing, full weight bearing at the end of 3 weeks. And the active exercises should be after 1 month only.
Okay, sir.
Again, it depends on what all you do. If you do a tibial tubercle transfer, then you have to go a bit slow, because you have to wait for that to heal.
Yes, sir.
If any other question you have, please ask. Yes. So I think most of the thing we have covered, sir.
Yeah, I think thank you very much, Arvind, and thanks everyone for.
Sir, just one question I have, sir, in my chat box. Considering the fact that most of the recurrent dislocation of patella improves with age and exercise, when it is essential to operate in a child. This is asked by Dr. Sanjay Gurai.
So the pediatric recurrent dislocation of patella, that is something very important topic. So one is recurrent subluxation of patella, another is recurrent dislocation of patella. So some pediatric patient those having recurrent subluxation of patella, as I said, so having associated hyperlaxity. So such type of patient should be focused on the exercise, VMO and the core group of muscle. But literature says even though these type of patients don't get 100% fine, there is some part associated subluxation remain there. But those who are having recurrent dislocation of patella, it means there is some anatomic problem with this patient. So that should be identified. And if you are treating this pediatric patient, the bony surgery should not be done. So you have option for the MPFL, the proximal realignment, VMO advancement, and the distal realignment in form of Roxgold with this procedure, Imslat, Trilet, all these procedure is there, soft tissue procedure.
Yeah, I think.
And in adolescent also, sir?
Sorry?
Pardon?
In adolescent also, we should avoid the bony procedure?
Well, adolescent is a wide range. By the time you're 16, then it doesn't matter. Okay, so because growth, at least in girls by 13, most of their growth is done. So if the epiphysis is used, you go ahead and do whatever you have to. But usually, so that's the thing. So if you have a true dislocator, it very rarely will sort of. So when you can actually or habitual dislocation, those will never get better with conservative treatment. You'll have to. What was I going to say about that? The other thing is the only time, so even in a patient, a pediatric patient, you may have to do bony surgery for correction of deformities. Okay, so if you have a severe valgus, you're going to need to deal with it. You can do sort of
Rotational
modulation, but sometimes rotation and very severe valgus, you're going to need to correct them to also get your patella realigned. Okay, I think we should call it a day now.
Yeah, thank you so much, sir.
Thank you very much.
It was,
Thanks, Arvind, for an excellent presentation.
And very rich discussion also.
Yeah, okay. So that's, I think this is an area which needs to be understood properly. And there's a lot of literature on it in the recent sort of journals. I think 15, 20 years ago, it wasn't some area that was well understood, but I think now it's reaching a stage where there's too much on it, so it becomes more confusing. Okay, so thank you, everybody, and until next week, we'll see you again.
Thank
Thank
you,
you,
sir.
sir.
Thank you, sir. Good night.
Thank you, sir.